Ladies and gentlemen, welcome to the Case for Street Medicine, the Detroit Experience. Your host, Ms. Ashley Lee, will now begin.
Welcome to our Disparities in Cardiac Health June webinar. I am going to go over a few announcements before I introduce our speakers. Self-addressed stamped postcards were mailed to our practices, so we're looking for those. And please provide us with any feedback on times that would work best or topics that you are interested in hearing. Best practice, change practices have started to be distributed to practices. The Governor's Award of Excellence overview and guidelines have been distributed to practices. If you have any questions, please contact Melissa Ottinger. Data submission will be due on July 15th. Look for reminders coming out in July. Any questions or technical assistance, please contact us by email at DACH@mpro.org. If you would like to be placed on our volunteer email list, contact one of the DACH team members or our DACH email. We have a few upcoming events. First is June is National Men's Health Month. The goal of this month is to increase awareness of preventable health problems. Talk to your patients and loved ones who are men about preventable health problems and the importance of seeking medical advice. Our next DASH newsletter will be out in August. And mark your calendars for our July webinar with Danielle Losbrock. She will be presenting motivational patient interviewing. We will also be holding a book interest screening on July 17th or July 27th at Belle Isle from 8:30 to 12:30 p.m. If you would like to volunteer for this event, please email Dan. For more information, be sure to visit our MPRO website or contact us at dash@mpro.org. I'm now introducing our speakers. We have three speakers today from Street Medicine Detroit. Johnny Wong is the founder of Street Medicine Detroit and serves as the organization's president in 2012-2013. He also is entering his third year of medical school at Wayne State University School of Medicine. Allison will also be joining us, and she's serving as the president of Street Medicine Detroit for 2013-2014. She will be entering her second year of med school at Wayne State University School of Medicine. And Dean Carpenter, a family nurse practitioner, is the clinical preceptor for the Street Medicine Detroit program and has been working in homeless shelters for 7 years. He also works part-time at the University of Michigan's Chest Pain Center. I'm now going to pass the ball on to Johnny, and he will begin. Welcome, Johnny.
Amazing. Thank you so much, Ashley. We really appreciate this opportunity and platform just to share about our program. And we've really only been in existence for less than a year, so for all the attendees, we'd love to hear any feedback or questions or anything that you think might help us increase our reach and our impact. So, with that said, we can start, but actually, and we're called Street Medicine Detroit, but, you know, a huge driver of our program is actually neighborhood service organization, and so they do a lot of work in the community, and especially with the homeless population. And we'll share a bit about particular individuals who help make this program function, one of whom is, of course, Dean Carpenter, who is with us today and will be sharing with you. He's really our clinical guru and medical director, basically, for the program. And he certainly helps us deliver continuity of care. So, I first wanted to give you guys a bit of a backdrop of what the state of homelessness is like in Detroit, and perhaps you're already a little bit familiar, but, you know, I am from Canada, and I came down to Detroit for med school, and just seeing these numbers, I first came across them in my first year of medical school, and they literally did blow my mind. These numbers are a bit outdated, but Right now, we're at about 19.5K homeless in Detroit, which is still a mind-boggling figure to me. And when you're out on the streets, at least as much as we are, and even if you're just out and about in the city, just doing your thing, you know, like you see the plight, you see a lot of homeless roaming about, and certainly we hope that this program is helping to address a lot of the disparities that they're currently facing. So we know they are a very complex population to work with. You know, obviously a lot of mental health and substance abuse issues. Some of the things that we're going to be talking about today, obviously this being part of the DACH program and disparities in cardiac health, we're going to be talking a bit about some cardiovascular issues that they have and that we've encountered, and just bringing some numbers to how we might be able to get some cost savings. But I know the difficult thing is measuring something that's never actually happened, right? In terms of, oh, we treated this patient with X, Y, and Z, and we therefore prevented something, but we don't know that we actually prevented something. But Allison's going to unpack that a little bit more for you guys. And I should have mentioned a little bit earlier about sort of the outline. So I'm going to be sharing, again, obviously about the state of homelessness in Detroit and also our mission, goals, and objectives. Allison's going to share about a little bit more about our partner organization that we do a lot of referrals through, that being Neighborhood Service Organization, as I mentioned earlier. She's also going to be bringing to you guys a little bit of metrics to support what we're doing. And then Dean's going to add some color with stories and anecdotes of our impact on the ground level, because we are really quite literally out on the streets and in shelters directly engaging the homeless population. So there's a study done in Detroit, and actually nationally too, but the site that conducted it here in Detroit, you know, you see this trifecta. I'm looking at the tri-morbidity line right here. And yes, while we are a little bit below average of tri-morbidities, that being some sort of physical ailments, substance abuse issue, and mental health issue, there is something about Detroit that makes it a lot tougher for the homeless to survive, particularly the unsheltered homeless. Obviously, with winters, you know, we're going to see a lot more cold weather injuries, and that's something that we've seen a lot, and Dean does address on a daily basis from his outpatient clinic at NSO. And you can see, sorry about the drilling, if you guys could hear that. You can see at the bottom here the percent vulnerable, at least relative to the rest of the nation. You know, as I mentioned, there is something about Detroit that makes life a lot tougher on the homeless. And just speaking to this trifecta of tri-morbidities, I think there's a study that showed the likelihood of mortality is 3 to 4 times higher for the people of Detroit. And we certainly see it. Like, a lot of the people that we encounter are, you know, you talk to them and they say they're 30 years old, but they really look so much older than their stated age. And just the weather and substance abuse and mental health issues are really, really impacting their lives. And obviously, you know, there is a significant impact on local emergency departments. This is from the same study, and some of the numbers are the same from the previous slide, but they sampled a total population sample size of 211. But you can see here at the bottom here, $1,638.10 is the estimated cost per day to treat frequent users, and there are a lot of frequent users, particularly amongst the homeless. You know, they may not necessarily be using emergency departments for health services, but more so just to have a place to stay for the night, or to get some food, or to, I don't know, enroll themselves in or not necessarily enroll themselves, but there's, what's it called? it's escaping me right now. But there's, for anyone with like emergent psych conditions, they can go into the DRH. So there's, we hope to be able to mitigate some of these numbers. We know these costs come at a cost to the hospitals and local health systems. So being able to provide front-end care and prevent these admissions is one of our goals. And I'm going to share a bit more about that in a bit. So about us, we, if you look at the top left box, to ensure access to quality primary and preventative care for the unreached and service-resistant population, that is really our target population. We, obviously, with there being 20,000 homeless in Detroit, we can't reach all of them, unfortunately, but we would like to go for the most vulnerable of the vulnerable. And a big part of what we're doing here was inspired by Dr. Jim Withers, and he's a physician out of Pittsburgh, and he runs a program called Operation Safety Net. And his whole mantra, if you will, is to quote-unquote go to the people and to meet them where they are and to see what conditions they're living in and understand their world so that we might be able to better empathize and better treat them and get a better understanding of, the sphere that they live in. So we're going after the unsheltered, the uninsured, people who would not otherwise self-select for services. And by services, I don't mean just health care, but any other social and supportive service. Another big part of what we do is by going to the people, we hope to bridge gaps between the homeless and medical communities. We've heard a lot of stories from the people that we encounter about how they feel very transparent whenever they are seen by a provider or even just people walking down the streets, as if people just look right through them and they don't exist, and it's like they aren't human, you know what I mean? So we hope that by us going out to them, it speaks volumes to them and tells them, hey, you know what, there are people in this community that care about you, and we just want to care for the community, and especially in a place like Detroit where there is so much plight. And as I mentioned before, at the bottom left, it's not just health issues that we're hoping to address. They do have a lot of socioeconomic and psychological issues that need to be dealt with. And so this is where a lot of our partnerships come into play. We do have a revolving door of medical student volunteers. And Dean is again, as I mentioned, a stable provider for us, but there also needs to be a lot of outreach workers and social workers doing stuff on the front and back end, and also referrals to like psychiatrists and whatnot that we got going. And finally, just to mention briefly, we do think that this is a really unique model for medical education. This experience is not unlike, it's not like a lot of other experiences that students would necessarily get at a regular outpatient clinic. We're meeting with the most vulnerable of the vulnerable, and like right on their turf and on their terms. And I think it does take. We are trying to drive empathy towards this mission. We call this the street medicine movement, and to this point, there isn't a lot of, in terms of specialties in the medical profession, like there's no quote-unquote street medicine residency program. And I think there could very well be one. The practice of street medicine is very different from any other practice, and we think, change like this takes a generation to make happen, and so we're hoping to help drive and facilitate that. So, how we hope to fit in, if you look at this middle turquoise box, so we want to provide targeted upstream care directly on the streets and on the street and shelters. And by targeted, like we want to provide continuity of care, again, as I mentioned, to that target population I mentioned earlier about the unreached and service-resistant individuals, and therefore avoid emergent downstream care. And doing this, it just makes sense, right? Like obviously if you do that, you're going to decrease costs, which Allison will talk about in a bit. You will, of course, increase access, and a lot of these people aren't going to self-select for care anyways. And hopefully, if we do it right, we will improve outcomes. And so what we're working on right now on the front end, you'll see on the far left here, coordinated discharge planning of frequent users. We're in touch with local emergency departments at DRH and also at Henry Ford about trying to set up a plan of sorts to reach out to their frequent users. And of course, healthcare provider support comes into play. And on the back end, we hope to enroll people into insurance, and especially with the ACA coming up. And whether we're their primary medical home or not, it all really depends on who they trust and what they want to do. And I mean, we'll refer them appropriately. Some of them do have PCPs already, and so we'll try and get them reconnected there. And Allison is going to talk about the PAP and Road Home. Those are programs run out of NSO, and so they're basically like our social workers. So very briefly, this map was made in January, and it's not necessarily complete, but you can get a bit of a picture of where we do most of our work, mostly within the downtown area of Detroit. We've hit a couple of sites on the east and west ends as well. So we did want to share pictures of what our outreach actually looks like. We are actually out on the streets looking for these particular individuals. This was one of our very first street runs. You can't see his face in blue here on the top left. Luke Brown, he's one of our social workers. We call them street navigators actually, and they help us. They are the face of the organization, at least from the perspective of our homeless clients. Because they are out there regularly and, are building relationships with these clients. We trust them to lead us to the right people, basically. And one of the things that we do on the back end is to do chart reviews so that we're determining, okay, what next steps do we need to take for specific patients, for instance, and how are we going to get to them, because they're obviously a very transient population. Here is underneath a tunnel on the bottom right in the picture. You can just see the conditions that they live in, and they're not pictured here on the left are a number of beds that are set up, and just a little bit of a glimpse of the world that they live in. So here is, what's that park's name? Savage Park. Okay. So when you're actually driving along, we rumble down the streets in a van, and so when you're driving along, looking for people to outreach to, you wouldn't know that there is actually a bit of an encampment over this little bridge, or not this bridge, this little hill, and behind it, this is Savage Park. There's some people living here, and you can see. I think that's a sleeping bag and a bunch of waste. So it's really important that we are physically out there outreaching and building relationships and a rapport with these individuals and establishing that trust to get them roped into services again. So this four-letter statement, go to the people, it's just really, really powerful, and it is guiding in many ways to what we do. Again, here's just some more images of the outreach that we do. There's some medical students doing patient interviews, and you can see we're really trying to mirror the patient's body language, and just I think it's important not to look down at them or and just meet them at eye level. I think it makes them certainly a lot more comfortable and a lot more open to share. We've heard from, again, the presentation's name is The Case for Street Medicine. And one of the things that we keep hearing about the value of what we do is from the social workers saying, when we are talking to these individuals about, their drinking habits or any substance abuse issues, Sometimes it's hard to elicit that type of information, but when they're bringing out medical students and healthcare providers, there's a little bit more, at least from the perspective of the patient, a little bit more credibility in saying, okay, these guys are in the healthcare field, and I can share about these things a little bit more freely, or at least they'll be more comfortable to do so. And of course, eliciting that information is important in history taking. And so here we are at St. John's. There's Dean on the right, the one and only. And here is just a big picture view of how we do it. These are, on the left side, it's just all the human resources that go into each individual street run, as we call it. So there's the provider, typically Dean. We've had physicians come out on the odd occasion as well. And the social workers / street navigators, there's usually 2 of them that come out with us, and then 4 to 5 medical students. And so, as I mentioned earlier, we do chart reviews on the back end, and of course we're documenting records and making referrals as necessary. And for the individuals that we deem that basically fit our target population criteria, we'll try to follow them as best as we can. And so we have been able to get some pretty good outcomes, which Dean will share about in a brief bit. So with that, I'm going to pass it over to Allison, who's going to share about path and road home referrals, and also the metrics that we've been able to get over our short existence. So I'm still going to be doing the slides, though, right?
Yeah, sorry. Thanks, Jonathan. The computer I'm using says that the software isn't supported, so Jonathan's going to have to click in the slides for me. But so as he was saying, we're partnered very closely with NSO, so Neighborhood Services Organization. So it allows us to be more equipped to care for the whole person. Medicine is just one aspect of complete care. So I was actually talking to Luke Brown, who Jonathan mentioned earlier, and he was explaining their social services to me as kind of triaging the client so that we can know which program would be most beneficial to them. For example, as the chart shows, you can see that PATH is a little more specific to mental illness. So if the client meets these qualifications and even has a small income, then PATH can actually pay for their first month's rent or their security deposit. So it can be very beneficial. And also Road Home is the other program. Road Home is the one that takes us out in the van right onto the streets to find the people in need of medical care. It can also assist them if the client needs to find housing or is ready for alcohol or tobacco cessation. So there's a picture of the street run in front of the Road Home van. So the 2 in the yellow jackets are our street navigators, which Jonathan talked about, and they're also kind of outreach workers, Mr. Ramsey and Ms. Coleman, and right in between them is Dean Carpenter. And with them is 4 medical students. And this woman's story is why I feel it's so important, our partnership, and why it can be so impactful. So Deborah scored the highest on the vulnerability index in Detroit, so that means that she had a very high likelihood to actually die on the streets. In this first picture, she entered the homeless services at NSO, and she had multiple poor social determinants, which is including the trimorbidity that Jonathan spoke of. And then the second picture here, this is after she had received supportive services for 11 months, which included mental health, substance abuse, primary health care, and transitional housing. And she was actually reunited with her teenage son. And I heard this story in the beginning of last year, right when I was getting ready to get involved in street medicine. And I just realized, if only her medical concerns were addressed, her story could have ended up very differently. You really need to care about the whole person in each aspect of their life. All right, so now I'm going to talk about a few numbers. I'm going to preface this with saying some of these numbers actually just come from the beginning of our operation. So that was from August to December 2012, where we were still working out a lot of kinks. So some of the data might not be as complete as we would like, but I really hope I can give everyone a picture of what we've been able to accomplish and what we hope to accomplish. So since our beginning, under a year, we've been able to get on 37 street runs and see 154 patients. And I think the most important number on this slide here is actually that 11 follow-ups. We've been able to build relationships with these people and help ensure them get refills, that they're taking their medication properly, and really hoping that we're catching any complications of their diseases in the earliest stages. So our goal is just to keep this number increasing and so we can increase the continuity of care. All right, so as I mentioned before, some of this data might not be quite as complete as we like, so that big chunk of unknown, 63%, can be from the interviewers might not have actually asked the patient, but also a lot of patients really just don't know their insurance status. But of the ones that we do know, 2/3 of them, that 24%, are our target population, the uninsured. So it's actually really encouraging to me to know that we are reaching them. And as Jonathan mentioned before, that 12% of insured is going to grow quite a bit after the ACA kicks in. So as of now, we kind of see our role as helping people sign up for insurance, which is probably going to be mostly through hooking them up with case managers through NSO, but then also finding good primary care physicians. So it's going to be a lot of partner building within Detroit, just to know that we can send them to trustworthy doctors that they'll feel comfortable with. So substance abuse. Yeah, we definitely see a lot of people struggling with addiction and substance abuse on our runs. And again, it's part of that trimorbidity, which increases the medical vulnerability and also just increases the mortality rate in general. These numbers are self-reported, as Jonathan was talking about, when our volunteers go out and interview them. So the numbers actually might be kind of low if the patient didn't feel comfortable admitting this, but to me, it's encouraging that these patients are willing to speak to our volunteers about really hard issues within a half-hour interview. To gain someone's trust that's been hurt so often by the medical field, I think it's a really special moment, and it hopefully shows the respect that's displayed by our volunteers to the patient and also from the patient to our volunteers that that they would feel comfortable enough and hopeful enough that we can do something to help them. Right, and here's just some common conditions we see, and they're compared to the national average. So the SMD patients are in red, and they tend to be higher than the national average, which is, I don't know, we would expect that. And here's a list of some of the conditions our team has caught. And again, Jonathan mentioned earlier that our patient population is one that's much more likely to use the emergency department, even when it's not an emergent visit. So these are some things that can bring people into the emergency department. And some of these things, if caught earlier, they wouldn't need to use that. So one way we see SMD playing a role in some potential savings costs is decreasing these non-emergent visits. Okay, so I'm going to touch briefly on two of the more common. Oh, you can keep the slide.
Oh, sorry.
So then two of the more common conditions we see, diabetes and hypertension. Now if we kind of talk about how street medicine may be able to cut down on the total healthcare costs, and so yeah, Jonathan pointed this out too. It is hard to account for a negative. So how much are you saving when you're not going to the emergency room? Or can you be sure that because of this care you gave them, they didn't go? So hopefully we found some studies that show that there are cost-saving benefits with when you increase the adherence and you increase the continuity of care. So yeah, here the national average for an emergency room visit due to diabetes is about $800. If the emergency room visit is due to a chronic complication of diabetes, which is often worsened when you don't have the proper primary care, it can almost be $900. When you compare this to just a patient assistance program at like $48 to $120 per year, it's a huge savings if the patient can continuously get their diabetic medication and go to the ED even one time less. So another study that we found, it was comparing the hospitalization rates within the diabetic population, and the only difference they were comparing was if the patient had insurance or not. So our target population is the one without insurance, and they're almost 3 times more likely to be hospitalized, which is creating costs that this patient can't pay for, and it also increases the burden on the healthcare system. So the lack of insurance to me means that they're not getting the routine care. It's making them more susceptible. So when they get sick fast, and they do need that extra care when they're sick. So hopefully these are the people that we want to catch before an actual hospitalization is necessary. And so lastly, we found a study on hypertension care, and it showed that with high adherence, there was actually an increase in medication costs. But this was because the patient was actually taking it correctly and were consistently getting their refills. However, there was that overall decrease that we were looking for in the medical care. And they showed this in a decrease in hospitalizations, a decrease in outpatient care, and especially a decrease in emergency visits due to their hypertension. So I just feel like this is really hopeful in that street medicine can play a major role in helping increasing the adherence in our population by making this medicine available and just increasing that continuity of care that we're looking for. All right, well, that's all I really had to talk about, and now Johnny can pass it on to our one and only Dean Carpenter, and he can tell you a little bit more about the stories of the patients that we get to encounter.
Well, thank you. This is Dean Carpenter. I'm a nurse practitioner at NSO and clinical preceptor for Street Medicine Detroit. I'll talk with you about some of our success stories with Street Medicine Detroit. The first gentleman is Mr. T.W. He was encountered at a shelter on the east side. That's actually Dr. Withers doing the assessment. We were honored and privileged to have him come on a street run with us. So this gentleman had type 2 diabetes and had been out of his oral antihyperglycemics for months, so his sugar was out of control. We started him back on his metformin. The medical student did a great assessment of his mental health and diagnosed him with a generalized anxiety disorder at that visit. And we had him follow up with our psychiatrist a week later, who agreed and put him on medication to control his anxiety. One of the he had eventually had 11 different encounters with the road home after we saw him, and in one of those encounters, one of the outreach specialists just found out that he was a veteran, and even though he did not receive an honorable discharge, he'd had an administrative discharge. It turns out he was still eligible for medical benefits, and so now this gentleman is in transitional housing in Detroit at Pickett Square, and he's receiving comprehensive medical care at the VA Medical Center. Additionally, because of his trimorbidity, he scored high on the vulnerability index, meaning his risk of death should he remain homeless was high. Another success story was a young lady who had a developmental disability and seizures, and she had been bouncing from warming center to warming center. She'd been a client of another agency at NSO called Life Choices, and they treat adolescents and adults with developmental disabilities and behavioral disorders. They'd lost touch with her, so she's out there going from soup kitchen to warming center. She has no cell phone. She doesn't have a mailing address, no way for them to get in touch with her. Well, we'd encountered her a few times in 2 different locations, and the case managers at Life Choices saw our notes in the electronic medical record, and I was contacted by her case coordinator and asked that to pass the message on to the client to please contact them, and we did, and now she's in transitional housing at the Bell Building. The Bell Building is another great project that NSO has embarked on. They took the old Michigan Bell Building. I don't know if you remember that building that used to have the Yellow Pages sign tacked onto it right next to the Lodge Freeway. That has been rehabbed into 155 single-bedroom apartments for homeless people, and she's now currently housed there. This just gives a brief overview of some of the venues that we will do street runs. The first is a obviously unused, unkempt park on Shane on the Near East Side, and we were treating people who were just sitting around the park, some sleeping in the park, and also some sex workers who are walking up and down Shane. We can do point-of-care HIV testing, and we dispense condoms as well. Where there are some people sitting on a street corner here in Greektown on the right. If you pass these street musicians, you really don't give a thought to them. You may stop and listen, put a quarter or a dollar in the case, and move on. Well, it turns out the gentleman is unsheltered homeless, and his insurance is inactive, so he hasn't had access to his medication for a while. So we get him enrolled in patient assistance program, get his medication, get him stabilized. This was another success story. This gentleman was encountered at a warming center on the east side. He had coronary artery disease, ischemic cardiomyopathy. He had a mitral valve replacement. You can see the sternal wound there. So it was complicated by a sternal wound infection. He had a lengthy hospital course, was discharged with only 1 month's supply of medication. His insurance was inactive. He had no way of getting any additional medication. The discharge instructions said, well, he needs to follow up with cardiology. Well, fine, do that without insurance. See how many doctors you can shake out of the trees that if the patient has no way to pay for the office visit. Well, the road home was able to locate a cardiologist up in Macomb County who would see this guy pro bono. And Darlene Coleman, the one pictured earlier, actually transported him up there at night. This doctor agreed to see him after office hours, so it was like 7 p.m. And Darlene transported him up there so that this doctor could see him and make sure that he was stable and on the right medications. He also, eventually his insurance became active, and he's in transitional housing and now getting comprehensive care. This was just an interesting case. I thought I'd include this, a potential impact that we could have. This was a gentleman that was encountered at a warming center on East Jefferson. He's a survivor of the genocide in Darfur. His father was killed. His mother and sister both escaped. He was captured and imprisoned and tortured. These are cigarette burn marks. Aside from just providing him basic health care and enrolling him in programs to eventually get him housing, we could support his application for asylum now that we have documented evidence of torture. So this is, like we say, it falls into the category of potential success stories. This is someone that we certainly could help down the road. And that's it for our presentation. We're open to any questions.
Operator, can we open the line for questions, please?
Yes, ma'am. Ladies and gentlemen, at this time, if you have any questions, please press the #1 key on your phone. Again, if there are any questions at this time, please press the #1 key on your phone. Our first question will come from Dr. Stephen Switch. Please go ahead.
This is Dr. Stephen Sweetek. How are you? Calling from Macomb County. Who's our cardiologist? I want to compliment him. Probably one of my buddies.
Dr. Schreiber.
Schreiber's a good guy. I think he's pulmonology, too, if I'm not mistaken. If you do talk to him, tell him Sweetek said hello, and thank you.
All right.
You alluded to this stuff about the military, gentlemen coming back. I don't know. I don't know if you got the numbers or not. I think 10 to 20% of our military coming back are homeless. That's a crime and a shame on the United States. These guys are in active combat. They come back and they have a home. They can't take care of themselves. Has the Pentagon or military thought of that? Is there any way? Is there a way we can contact these guys and get something going? I mean, I'm glad you took that building for the Bell, Michigan Bell. There's so many empty buildings. You mean they can't rent one out, put somebody in there to watch these people, feed them, have a shower in there or something? It's a crime.
Yeah, it is. It is. You know, I think everyone would agree that the veterans have earned their health care.
I agree with that. This thing also about Obamacare, and you know, I'm personally one of these people that believe that every American should be entitled to health care. I just hope Obamacare doesn't give a little of nothing to everybody and it doesn't change anything. At least now we're seeing some of these things come into fruition, and I laud them for his attempt to get health care. That's all. Thank you.
Thank you.
Again, ladies and gentlemen, if you have any further questions, please press the number 1 key on your phone. Again, if you have any questions at this time, please press the number 1 key on your phone. Our next question will come from Michelle Bryant with Wayne State University. Please go ahead.
Hi. I am curious if you all have established a list of resources for this population that you are to share with the rest of us.
I think their list would be somewhat fragmented in that we kind of generally have a list of sort of healthcare related resources, and then I'm meaning us as in the medical students and myself. And then the road home and path have much more extensive resource lists for social services. But we're all sort of on the same page, and we will refer rather informally on the spot, sort of a curbside referral. And so to answer your question, I don't know if we do have a comprehensive list because it would be quite extensive.
Yeah, if the ball's not on me, can you guys still hear me?
Yeah.
Okay. Yeah, another student organization actually is developing a more comprehensive list. But one of the things, you know, I'm not entirely sure about the utility. Like, it is important to have that list, certainly, at least from our standpoint, I think, knowing what is available. And yeah, certainly giving such a list to the homeless client that we're working with would be valuable too. But I think because our system is very fragmented, I think, and we don't want to keep having the patient bounce around from one provider to the next and not really get that continuity of care. And we aren't trying to like monopolize or like take over the care of certain individuals. Like if they have already been seen by someone and have a relationship with someone, but then suddenly lost touch for whatever reason, then I think we would want to reconnect them. So I think we see our role as being a connector or a reconnector, and also possibly being a patient's primary medical home. And a lot of the, like Dean mentioned, a lot of the social services will go through path and road home and rely upon their expertise and connections for that.
Yeah, I think that's something. Oh, sorry. Go ahead. Oh, sorry. I think.
No, I had nothing else.
I think like a resource list or a referral list is something that is useful. Although, yeah, it is very individualized. Finding someone that can help that individual patient when we see them on the street. But yeah, the sharing of resources is something that we really want to develop over the next few years to kind of connect all these communities that are working together. Just so we can, if we're all working to help the same population, we can obviously help them more when we're working together and sharing any resources that we have or that we can find. So that's something, a goal of ours in the next few years.
Again, ladies and gentlemen, if you have any further questions, please press the number 1 key on your phone. There are no further questions in queue.
Operator, if we have no further questions, I'd like to start our survey, please.
a side note, actually, to the first question, the numbers for homeless veterans in Detroit is on slide number 4.
I would also like to thank Johnny, Allison, and Dean for a wonderful presentation and all the work you're doing.
Thanks for having us.
Well, next,
should I take the survey?
Allison, if you'd like to, that would be wonderful.
Okay.
And we'd love to connect with any of the listeners at a later date.
Yeah, is any of our contact information available, like the email address up there?
Allison, if you'd like to put your contact information in the chat box, then our attendees will be able to have the information. And I would like to ask all of our attendees to please take the survey on the right-hand side of your screen.
Nope. Oh, there you go. All right, so if anyone has any questions and wants to send me an email, I'll see you now.
Allison, thank you very much. Johnny, Allison, and Dean, thank you very much for this presentation, and I look forward to continue working with NSO and street medicine.
Thanks so much for the opportunity. Really, really appreciate it.
You're welcome. And I'm going to go ahead and end the webinar.
Yeah, and also, Dean just posted the link to our website if any of you wanted to check it out. It's streetmedicinedetroit.org.
Thank you very much.
Thank you, ladies and gentlemen. This concludes your call. You may all disconnect.